program specifically designed for child welfare-involved youth, as well as hear about our youth system of care for substance use treatment services. We'll go over some housekeeping items. Bertha?
Hello, good morning, everybody, and thank you for joining us today. I'm just going to briefly go over some housekeeping items just so we're all on the same page. So you all should have gotten some sort of notification that the webinar is being recorded. Our plan is to make this available to all of you, and we will send out some more communication as to where you can find the recording at a later time. Currently, all participants are muted. Questions and comments should be typed into the Q&A box. We will be answering questions at the end of the webinar. Materials for this webinar will also be available after the session and sent via email. And you will receive a survey link at the end of the webinars in order to provide us with some feedback on our event today. As this is an annual fair, and we hope to take your feedback and make next year's event even better. Thank you.
Okay, so the next thing we're going to do is just a simple word cloud. And so we have some instructions in the PowerPoint of how to do that. We just want to ask you a simple question, and that is, in one word, what does wellness mean to you? You can either, you can text the number 22333 and the following code, Frank G011. You will receive a text from Poll Everywhere. You can ignore the hyperlink in that text and just respond with your answer in the text box. Again, the question is, what does wellness mean to you? So you can take a moment to do that. Okay. Can we see the cloud, Frank? Seeing some responses come in. Please keep adding. Great, great. Stability, care, meditation, peace, health, sanity, hiking. Great. Prayers. Self-care. Great, thank you, everyone. So we will be hearing about some wellness services for our families and youth today. We're also going to do a little poll to see who's in the room today online. And so if you can just take a moment and briefly respond as to where you fit in: caregiver, community partner, DFCS, behavioral health, or other. Just give it another 10 seconds or so. All right, I'm going to go ahead and close the polling. So we have quite a few DFCS social workers, some behavioral health, community partners, and a caregiver here today. So welcome, everybody. It's nice to see you all join us today. So we're going to go ahead and get started on our presentation. So I'm going to invite Gail Petzo to begin with an orientation of pathways to well-being.
Good morning. Thank you, Melissa. I'm going to give you a very brief overview of the continuum of care of mental health services that are available for our youth who have an open child welfare case or are receiving services through the Department of Family and Children's Services. When the family begins to receive services through DFCS, the Welcoming Center will send a Pathways to Wellbeing screening to the Pathway to Wellbeing coordinators who we are embedded in the DFCS office over at Julian when we're working in the office. Right now, we're currently all working from home, but we work very closely with the social workers. And once the social worker is assigned, then the social worker every 6 months will update the Pathways to Wellbeing screening and send that to us, or if there's a change in circumstance. And based on the information that's in that screening, the Pathways to Wellbeing coordinators, Janet Cadillo, Marcy Sandate, and myself, make a determination of what level of mental health services are available through the continuum of care and that would best meet the needs of that child. The Pathways to Wellbeing coordinators also can make direct referrals to KDA intensive services for families who are receiving services through the Department of Family and Children's Services. And now the Behavioral Health Call Center can make direct referrals for KDA intensive services for families who are not receiving services through the Department of Family and Children's Services. And for any youth that are living outside of the county who've been placed outside of the county through the department, the social worker completes the presumptive transfer packet. And in that packet, they include the Pathways to Wellbeing screening, which also social workers know as the SCZ 61. They include that with the presumptive transfer packet and send that to the presumptive transfer contact person in the county where the child will be residing. If the child has private insurance, the social worker will have to help the family connect with mental health services through their private insurance. Once we've completed our recommendation and sent the referral for services, we will send a disposition email to the social worker letting them know what services we've referred the child to. For any youth who are really struggling, parents are struggling or foster parents are struggling with behaviors in the home, social workers also have services that they can request through the Department of Family and Children's Services. They can request placement post-supportive services, PSS, or intensive stabilization services, ISS. And they can also look at whether they want to look at interagency referral for wraparound services, or perhaps the child might need a specialized placement setting such as treatment foster care or short-term residential therapeutic services. But again, those services are referred through the department's placement unit. And then once the services through the Department of Family and Children's Services are ending, the social worker can look at whether or not they would like to refer this family for aftercare, which would be through the differential response program. And they would go to the differential response coordinators to look at that. Next slide, please. And this is the continuum of care that we can provide for our children and youth who have an open case with the Department of Family and Children's Services. And as you can see, it starts from left, goes from left to right, and the least intensive services and the least number of hours of services is on the left. And then it continues through the continuum to the most intensive services and the more hours to the point where it's residential treatment. And KDA intensive services are in the middle, and KDA is where we start to enter the team approach or the team model for families. And so families start to receive a team. They'll have a facilitator and a case manager and a therapist. And the number of hours increase as we go up the continuum and ends with the short-term residential therapeutic program. And for families, if a child might need therapeutic behavioral services, they have to have ongoing mental health services already. And that clinician will refer the family or the child for therapeutic behavioral services, which are short-term services and behavioral focused. And then we also have crisis services that are available to our kids and their families that are receiving services through the Department of Family and Children's Services. And so that is our continuum, a very bare bones overview of our continuum of care, but you're going to be hearing more about some of these services within this continuum this morning. But thank you very much. If there's any questions.
Thank you so much, Dale. We'll take those questions at the very end. I want to thank you for your introduction on the Pathways to Wellbeing program. We're going to be transitioning over to our Alum Rock Counseling Center to hear about prevention and early intervention services.
Hi, good morning. I'm hoping everybody can hear me. Let me just adjust my volume. Yes, thank you so much for being here this morning. Sad about the circumstances, but grateful we can still connect this way and share important information. So my name is Desiree Vega. I'm the program manager of our Prevention and Early Intervention program. And I just want to start off by sharing a little bit about our mission. So we can move to the next slide, please. So our program, well, our mission at the agency is to heal families and inspire youth to reach their full potential. Specifically to our prevention and early intervention program, our goal is to reduce, eliminate mental health symptoms that may be negatively impacting academic success and family wellness. So very much that keyword prevention, and especially during these times with COVID. I'm a mother myself, and I have seen the direct impact distance learning has on my son. Let's just say it's not the most positive. Of course, there's always silver linings, but just want to highlight that this time is very difficult as providers as well as parents and just individuals who have to work and care for their children. My program specifically, we target youth ages 5 to 13, not only the youth, but also caregivers as well. And so students who are experiencing behavior issues or displaying symptoms that have caused impairments. So for example, not wanting to log on to school, or, my son or daughter seems extra moody, life changes such as something like COVID and the grief that our children are experiencing with not being able to return to in-person services and school. As far as insurance goes, we accept Medi-Cal and also families with no insurance. There's absolutely no fees for our services, and our length of services are typically about 3 to 6 months, and our program does run year round. Right now, our services are being provided via telehealth, so like this, either through Zoom, Google Hangouts, FaceTime, whatever the student feels most comfortable with, because we do recognize that a lot of our students are experiencing Zoom fatigue just from being on the computer all day. And so some of them just prefer to just talk on the phone. And same goes for family sessions. Next slide, please. This is a little graph that kind of illustrates the different levels of care in prevention and early intervention. So we have our lower needs and we have our different tiers, starting with the family partner. And this person typically works with parents around anything around positive parenting. We use evidence-based practice such as Triple P, community resources, so linkage, for financial support, housing, food, and then the next level of care is our family specialists, who provide more behavior support so they can work with the parent and the student. And they work more on like disruptive behaviors, social skills, self-esteem, following directions, relationships, the importance of a routine. And then for our clinicians, which are considered our highest level of care, they're providing individual therapy with more specific diagnoses like anxiety and depression, major adjustments like COVID. And other ways we have been supporting to be creative is really a lot of outreach with providing free parent and family workshops, parent services, and also we've also reached out to teachers and validated them during this difficult time and provided some support on how they can support the students. And the next slide. Okay, I'm sorry if I'm speaking fast. I have my timer here. I want to be mindful of time of the other presenters as well. So this last page, if you want to take a screenshot or save it, I know that this will be emailed as well, but it has my information. It shares that the schools we serve are in Alum Rock Unified, Mount Pleasant, and Oak Grove. And if you have additional questions, my phone number is there. That is my work phone number. And just really want to thank everybody for providing me the space and time to share our services. Thank you.
Thank you so much, Desiree. I really appreciate learning more about PEI services and sharing that with all of us. We're going to be moving on to learn about SLS services with Guadalupe Ramirez. Welcome.
Hi, Melissa. If someone can allow me to start my video. Thank you. So yeah, my name is Guadalupe Ramirez. I'm with Behavioral Health Services and I work with Schooling Services. We are also part of the school system, but we support schools throughout the county in receiving universal access to some of our providers and prevention services that allow children and families to connect prevention methods and early intervention systems that some of our partners already, like Desiree mentioned, she's part of with Oak Grove, Alum Rock, and different community members. So I'm glad to be able to support this program and share with you guys the information we have today. Next slide, please. So Gail mentioned a little bit about this graph before on our continuum of care. If we could see here that prevention and early intervention is at the front tier regarding our services and our hours of care. And then at the end of that tier is residential. So schooling services is part of our prevention and early intervention systems. Along with outpatient services. Desiree is part with Alum Rock School District and prevention and early intervention. So she falls into that category of 1 to 4 hours in the lower end tier. So we have school link services, which is in the first column. So we see that this is part of the spectrum, that it allows families and students and parents in our 15 school districts that we serve in Santa Clara County to access universal systems of care, regardless of their insurance provider. We also have availability and support for families to engage with insurance providers so that they can get services like Alum Rock Counseling Center through Medi-Cal or through other partners, and be able to receive schooling services, behavioral support systems. Next slide, please. So these are the schooling support districts that we have a partnership with. This is really a resource linkage, and these schools and our initiative is really corresponding to support the school districts as a barrier for students to get services and not have to go through the normal passages that families usually have in our community as a preventative measure. So as you could see, we are in all of aspects of the county, North County, centralized, and then we are in South County. These are our 15 school districts that participate in the Schooling Services Initiative. We have contracts with all of these school districts. Not all of these school districts have all the components of PEI. Only 11 of them do, and only 13 of them have, only 11 of them have prevention and early intervention, and 13 have school-based behavioral health partnerships with our providers. And 2 of them do not have any school-based mental health providers, and they just follow the initiative regarding the support linkages that they have with our partnership with behavioral health. Next slide, please. So what does that mean for families and these school districts? What that means is that in each of these 15 school districts, there is at least one school social worker or SLS coordinator that supports families. So referrals are given to that coordinator with the identifying risk factors that the student has been referred to. That coordinator will address these risk factors and assess the need. That could be done through this referral linkage resource. It could be done through a family engagement activity or workshop referral. Home visits are also established. We can also see that they could be referred to a mental health group, or parents can refer to some type of group setting that is more on a least restrictive setting with our Tier 2 services. We also have referrals for individual therapy that address risk factors like attending school, mental health issues like depression, anxiety, bullying. With our Tier 3 services, there is also home-based services, which is our most intensive services with SLS behavioral health services. and parent coaching. So as Desiree mentioned, those are our system of care when it comes to the use of hours. We saw in the first column that it was 1 to 4 hours per month. When we go into outpatient services, that's when we go ahead and increase the usage of hours. So if there is a student or family member that is interested in having a referral, the parents are encouraged, or the teachers are able to do a referral on behalf of the student to the coordinator in these 15 school districts on behalf of the student, and that coordinator will proceed with addressing the referral to the appropriate service provider. Next
Thank you
slide,
so
please.
much, Lupe. That's really great to hear about all the services available throughout the county with SLS.
Yeah, thanks, Melissa. My next slide is just my information on how folks can go ahead and reach me. These are just activities that the county is also doing with schooling services. We can proceed to the next slide, that's where my information is available. And again, thank you again for being able to share this information with about schooling services and the knowledge we provide.
Thanks again, Lupe. We're going to be moving on to learn about the STOP program at Gardner with Bernadette Martinez.
Good morning. Thank you, Melissa. Can you hear me and see me?
Yes.
Great.
Go ahead and get
So,
started.
thank you. Good morning. So I'm Bernadette Martinez, Program Manager with Gardner Health Services. This morning, I will be sharing about the Supportive Therapeutic Options Program, also known as STOP. Next slide, please. So the STOP program is a grant that we have from social services, and it's a small grant, but it's a mighty one, meaning it serves all youth and families who are on the continuum of care. The program is serving families and youth who don't have insurance or are underinsured. Some families that we have served in this program either are families who have recently immigrated and are still connecting to their Medi-Cal services, or they do have Medi-Cal and we've seen that they have a code that doesn't access mental health services, or we've also seen and served families who do have private insurance but have a very high share of cost. So those are the type of families that we serve. And so STOP is created to fill in that gap, to serve families and youth with mental health services. So as you can see here on the slide, the target population is accessible to children and youth who are up to age 19. And as I mentioned, it's to access mental health services who have no coverage or are undercovered. It is also a program to prevent entry or re-entry into out-of-home placement, or also helping youth and families transition back into their homes. Next slide, please. Next slide, please. Oh, there it is. So the STOP program really serves our youth and families. Basically, we serve services that have, even if it's a family who has Medi-Cal services, what our goal is to help them access their Medi-Cal services. And so a lot of our providers are also helping them with their Medi-Cal eligibility and applications. While we're doing that, we're also serving them with mental health services such as individual therapy, rehabilitation services, assessments, plan development, medication and medication support with our psychiatrists, case management, as I mentioned, and our services are community-based, and we also serve in English, Spanish, and in Vietnamese. Next slide, please. So the referrals can be made directly to us at Gardner. Our phone number is 408-287-6200. And you can contact us directly. Mike Danner is the program supervisor and his email is listed below, or contacting myself or our senior program manager, Amy Rice. Any of us can help you with any questions you might have, if a family's, whether they're eligible or not, and also to directly refer a family into our program.
Thank you so much,
And
Bernadette.
if you have any questions, I can answer them. Thank you.
Thank you so much, Bernadette. Really appreciate your presentation on STOP. We'll be introducing Rick Navarro to talk about REACH services.
Good morning, everyone. Thanks, Melissa. So my name is Rick Navarro. I'm a social worker with the Santa Clara County Behavioral Health Department. I work for a project called the CHRP project, and our main role is to expand the REACH program. So that's what I'll be talking about. Next slide, please. So the mission of the CHRP project and the REACH program is to identify youth and young adults ages 10 through 25 who are at clinical high risk for psychosis, and to provide interventions to lessen the severity of a first episode of psychosis or to prolong it from happening. So what does that mean? Psychosis, first of all, is the experience of people who have a difficult time distinguishing reality from an internal experience, the symptoms of which can include bothersome voices, intrusive thoughts, disorganization, hallucinations, delusions, or confused thinking. When we say first episode of psychosis, that refers to individuals who are at the beginning of that illness, that disorder. But when we say clinical high risk, that means someone who has not had their first episode yet, doesn't actually have psychosis, but we're seeing some early warning signs that they may develop it later on, some changes in their perception, thinking, and their functioning. Next slide, please. These are some of the early warning signs that I was referring to. The behavior changes are things like extreme fear, uncharacteristic or bizarre behaviors, extreme social withdrawal, changes in their appearance, their hygiene, their sleep, their eating habits. Perceptual changes are again fear, greater sensitivity to the different senses, saying things like my brain is playing tricks on me, or someone is putting thoughts in my brain or taking them out, hearing voices or sounds or visual changes that other people don't see. Reduced performance would be things like difficulty understanding or reading complex sentences, trouble speaking or understanding other people, getting confused or lost easily, having trouble doing things that used to be easy for them, and attendance problems as well. Next slide, please. So this is where REACH comes in. So REACH is a collaborative program. It's run by two different agencies, by Momentum for Health and Starlight Community Services. They provide education, early intervention, and prevention services for this clinical high-risk population. Currently, they are doing teletherapy like many other programs. Each client within REACH works with a team. They work with a team including the psychiatrist, a therapist, an education and employment specialist, an occupational therapist, a parent partner, and a peer mentor as well. Some of the criteria to keep in mind is that it is for ages 10 through 25. They do have to live in Santa Clara County. They have to exhibit those early warning signs that I talked about in the last slide. The program is for individuals who have Medi-Cal or who are uninsured or unsponsored. They do need to be stable and able to engage in the evaluation process. So it's specifically what that means is that if they've had if they have active trauma or active suicidal ideation or have been hospitalized recently, they may need to they may need to be stabilized in the community program in your own programs first, or in a different mental health program before they're referred to REACH. The symptoms can't be due to substance use or to active trauma. They have to be due to this specific condition, and they do have to have a stable place to live. Next slide, please. The referral process, the most important thing to keep in mind is the REACH hotline, and that's 1-855-2-REACH-US. A client can call by themselves, you can call with a client, you can call for a client. They do an initial phone screening to ask just a few questions, and then they schedule a SIPS assessment, which is a longer assessment to determine if they do meet the criteria for clinical high risk for psychosis. And if they do, they work on transitioning or opening the client, and if not, then they discuss the results with them, and they can offer a care coordination to refer them to the appropriate program. And the last slide is my contact information. I'm at the bottom, and my Elisa Hamid is my supervisor. You can contact either one of us with questions, or you can call REACH directly as well. Thank you, everyone.
Thank you so much, Rick. Now we're going to be introducing Emmett Marsh and Adrienne Lopez regarding the Q Corner. Welcome.
Good morning, everyone. My name is Emmett Marsh, and I'm here with my colleague, Adrienne Lopez. I use he and they pronouns, and she uses she, her pronouns. We're going to be talking a little bit about our new program called the Q Corner. And we're just going to go back and forth real quick. So next slide. So our program is a fairly new LGBTQ support program for those seeking different services within the mental health care system. So we provide access and linkage to different resources and referrals within our county and some externally. Our mission is to support the LGBTQ community in Santa Clara County through direct services, access and linkage to community resources, and building affirming services and delivery systems. We also help with SOGI 101, sexual orientation, gender identity, gender expression trainings, and other specific trainings as to working with the LGBTQ plus community. And our program is free. We accept all ages, and we're able to connect folks with pretty much any other mental health service that is applicable within the county. Next slide. So we have a lot of direct support services, peer support, knowledge of all county resources and referrals, so we can connect and refer folks to different programs that have specific experience with working with the LGBTQ plus community. Next slide. For community building, we're starting these new Q Corner chats, we're calling them. So these are info sessions on subjects relevant to LGBTQ plus folks, hosted in collaboration with local expert panelists. On the 28th, we're actually hosting one with Oasis Legal Services about LGBTQ plus asylum in the US. So if anybody has any questions, my contact information will be at the end, so we can send you to that. We have different trainings that we're focusing on, which I mentioned earlier. And if anybody, again, has any questions about these, I can support and send all that information. We have a lot of stuff going on with trainings. We can go to the next slide. And here's our contact information. So we do have a bunch of different social media for contact, and email or phone to reach. And we do have that website that we are currently still working on. So thank you, everybody.
Thank you so much, Emmett. Appreciate the presentation. We're going to be moving on to differential response with Susan Smith and Ty Garrett from Seneca.
Can I need to get my camera on. Okay. Can you see me? Good
We can
morning.
see you. Well,
Good morning. My name is Susan Smith. I'm the program supervisor for the differential response, and I'll be presenting with Ty Garrett, one of our support counselors. Next slide, please. This is our contact information, and generally you can reach me, or if you want just general information about our differential response program, you can call that number, or that's our website, which kind of gives you a little additional information about Seneca as well. I just wanted to talk a little bit about Seneca's vision. We provide services in an integrated, engaged approach. With high standards of practice. All Seneca services are designed to be flexible, individualized, trauma-informed, and culturally responsive. Next slide, please. Okay, I want to talk a little bit about our referral process, just so you have an idea of exactly how we refer our families to the program. The referral process starts with CPS. A family is engaged in CPS, and then it's referred to the county, who then assigns it to a social worker, and then we get the referral. Part of what we do as a way to engage families is that I am the initial contact for the family. And then once I've contacted the family, I then assign it to either one of our support counselors or to one of the clinical therapists. And that's really based on the needs of the family and also based on the type of insurance that the family has. We do accept families with or without Medi-Cal, but we do make sure that we want to make sure that the services are sort of targeted and sort of tailored to the family's needs. I'm going to allow Ty to talk a little bit more in specifics about exactly what we provide to the family. Ty? You have to unmute yourself.
Hi, Susan. Looks like I may have lost connection.
Can you hear me okay now?
You're good, Ty. Take it away.
I'm sorry about that. I'm having a lot of connection issues today. But basically, a lot of what we provide in differential response is case management, mental health linkages, things for helping families to be more self-sufficient if they need help with employment or basic living needs for housing, food, clothing, help with their utilities or PG&E. We help with that. If it's mental health, we have our own services. Like Susan mentioned, we only take Medi-Cal clients, but if they have other insurance, we'll do stuff like we'll check on them and how their process is going with their own mental health linkages and seeing what families need or if parents need more parent coaching around a certain diagnosis that a child has, and just seeing how they need what the need is. If they need connections for substance abuse support or domestic violence awareness or anything with connecting with insurance even. What kind of ranges. And something that makes us different from other differential response teams is that we provide a lot of cultural awareness competency within our meetings. So whatever ethnicity that a family is, we try to tend to that need and talk about, what is your tradition? What is important to you? What are your morals? What are your values? And how are you passing that to your children, along with different generational things that they do not want to have continue, that they know, oh, this is what my parents did and I don't like that. Let me change it within my own family. So we basically we see what the family's need is, and we just attach to them for 6 to 9 months, and we make sure that they feel supported and just kind of flow into whatever their routine is for their families.
And that's usually through the types of services that we provide, which is case management, mental health counseling. As Ty was talking about, our basic living needs. A lot of our families have a lack of resources. Our therapists really work with the families around child growth and development, because often parents need support around that. The support counselors, as well as the therapists, support the families around parent education. There's domestic violence awareness. We work with the families to become more self-sufficient, substance abuse support, and health and wellness. We didn't provide our contact information, but you can reach me through the general number, Susan Smith. I am the program supervisor. If you want additional information, or if you need you're interested in getting information about the referral. Most of our referrals come through the county. So that needs to be sort of the pathway in which we get our referrals, but we do have the ability to take some community referrals as well.
Thank you so much, Susan and Ty, for that presentation. We're going to be moving on to Hope Services with Linda Dino, Allison Murray, and John Robinson.
Is Linda there? Okay, so good morning, everybody. We're from Hope Services. I'm Allison Murray. This is John Robinson. And we are from Hope Services Mental Health Services. Next slide, please. Our mental health services mission is to improve the quality of life for individuals with developmental disabilities and mental health needs. Next slide. Our target population is children, teens, and adults with developmental disabilities who also have co-occurring mental health needs. For our referrals, people can refer through the Department of Mental Health Call Center. They can also refer through San Andreas Regional Center, which is also known as SARC. They need to have full scope Medi-Cal, and we also offer private pay. Next slide, please. For eligibility, they need to have a SARC qualifying diagnosis of a developmental disability with a co-occurring mental health diagnosis. They need to be a SARC or a SARC consumer who's referred to the mental health call center and live in the various catchment areas. Next. We're located on Parkmore Avenue in San Jose. We have satellite offices in various areas, and we're open 8 to 5 and have additional hours as needed on a case-by-case basis. Next. Our services for children and teens can include various different modalities of therapy, case management, psychiatric consults with child psychiatrists, and individual consultation for parents. Next, we also have our Therapeutic Behavioral Services Department, TBS, for children with extreme needs that have a history or risk of hospitalization or loss of placement, are at risk for losing placement, and they need behavioral one-on-one high-risk treatment. We also offer support for TBS families. Next. We offer services for adults, which can include various types of therapy, also such as dialectical behavior therapy, cognitive behavior therapy, and we also offer groups. Next. We offer case management, linkage to resources such as, for example, the EDD or National Alliance on Mental Illness. We offer psych services, assessments, and medication. We have an RN, and we offer groups. Next. We offer family support and education. We offer WRAP groups, Wellness Recovery Action Plan, and we serve folks with autism and co-occurring disorders. Next.
So
Go ahead.
I usually we do COVID exposure protocol with our health service and stuff. We follow CDC guidelines by using phone and health services. And also require mask wearing and social distancing and temperature check. Next slide. Now, as you can see, here's our information. Contact Alvarado and it's information. Thank you very much for having us.
Thank you so much for sharing more about Hope Services with everyone. We're going to be moving on to Justin Worth from Rebecca's Children's Services to share about the KDA program.
Hi, good morning, everybody. Hope y'all are doing well. Can you see me?
Not yet. We'll try to fix that also on our end.
Excellent. Let's see if I can pop up here.
We see you, Justin. You're good to go.
Excellent. Thank you very much. So good morning, everybody. My name is Justin Worth. I'm here to talk to you today about Rebecca Children's Services. I'm one of the clinical program managers over here, and specifically, we're going to be talking about KDA services today. So at RCS here, we have our mission and our vision. Our mission is very simple. We are committed to seeing our community flourish by building pathways to hope, happiness, and well-being. Primarily we aim to provide quality care, education, employment, really provide those services to our clientele. We have a wide variety of services, but I will focus on KDA today and talking primarily about coordination, it being client-centered, strength-based, and team-oriented. And we are very much, like many of you, a community-based mental health service organization. So our target population for KDA services, we serve youth ages right from birth up to the 21 years of age. A lot of our clientele tend to be youth involved in or at risk of child welfare involvement. And we also serve youth with significant mental health challenges and or concerns. What sets KDA services apart from a lot of other services is the need for complex care coordination across child serving systems. And I'll be talking a lot more about that coordination, which is a hallmark of KDA services. Some eligibility questions that typically come up. We are a mental health-based service, so youth must meet medical necessity and have a qualifying mental health diagnosis to receive and have these services. Child welfare and social services involvement is not necessary. We will see a lot of our clients and families come from those areas, but it is not a requirement. Typically, our referrals are screened by Santa Clara County Behavioral Health through the email that you'll see below. We receive referrals from DFCS, schools, Medicare, medical doctors, through the call center, as was previously mentioned. Medi-Cal is required for KDA services, and the youth must reside within Santa Clara County, but we do have youth coming through presumptive transfer in other areas of the state and sometimes around the country, but they are within Santa Clara County presently. So I mentioned intensive care coordination. That really happens to be what sets KDA apart. A lot of our youth are in need of coordination across multiple systems of care, across different care providers. And so as part of KDA, that is really a focus, having an intensive care coordinator that both facilitates ongoing child and family team meetings, as well as these services. We do have intensive home-based services as part of this. As this is a mental health service, we develop treatment plans with our client with those qualifying diagnoses. As part of that, if youth or families are in need of individual one-on-one services with either that youth, family members, caregivers, what have you, those can be built in. And we have adjunctive services. We do individual and family therapy, TBS, therapeutic behavioral services, as somebody mentioned earlier, family support, medication management, psychiatry can all be built in based on the family's needs. Really, our main objectives here are to restore, improve, support, and coordinate. Our main goal is to come into a youth or a family's life, find ways to restore functioning, support them with their needs, and then coordinate their ongoing services based on their needs. Next slide, please. I'm going to speed this up a little bit. I've hit my allotted time, but we are a community-based service. We meet the youth and their families in their home, in their communities where they're at. We utilize a strength-based, client-centered approach. Presently, we are doing telehealth, but we still meet members of families in communities. We're still meeting in homes, parks, community centers, but we want to meet the families where they're at, so a lot are comfortable with telehealth, and we're utilizing that modality as well. And as we move to the next slide, I can certainly say that we are a team-based collaborative approach. We utilize the integrated core practice model. And the last thing I want to say before my time is up is both a thank you for having me, and also if you need to make referrals, please feel free and contact the Behavioral Health Pathways email. I've provided behavioral health contact information here for that. Also on the left, you'll see Rebecca Children's Services. Our main office is in Gilroy, but we have an office in Campbell. We also have a phone number for the Salinas area. You're welcome to call and or email for referral needs and or any further information. Thank you very much for having me today.
Thank you so much, Justin. Really appreciate the presentation on KDA. We're going to learn more now about the Full Service Partnership Program from Bernadette Martinez at Gardner.
Thank you, Melissa. Let's wait for my video to come on. There it is. Okay, hi, Bernadette Martinez again, Program Manager with Gardner Health Services. I will be sharing about our full service partnership child program. Next slide, please. So our FSP Child Program is our highest level of care in our system of care at Gardner Health Services in our Family and Children Division. So our target population are ages 6 to 15, clients who are Medi-Cal eligible or unsponsored. They may have a history or current child welfare or juvenile justice involvement. They may have 1 to 2 hospitalizations or incarcerations in the last year. They're at risk of homelessness or becoming homeless due to their severe mental illness. We serve clients 2 to 5 times a week, and they need more than 8 hours a month. Next slide, please. So the services that we provide are individual therapy, rehab, assessments, plan development, medication support. We have peer support, and it's a interdisciplinary team approach. We provide case management, and most of our services are community-based. About 30 to 50% are community-based. We do provide telehealth when appropriate. Currently, most of our providers are still going out into the community, meeting with families face-to-face as needed, depending on the needs of our families. As mentioned earlier, they usually on average receive 12 to 15 hours a month. That's our dosage for this program. They do receive services 24/7, meaning there is a on-call phone number that they can call at any time, also on the weekends. And our average length of stay is about 9 months. The consumer ratio, staff to consumer ratio is 1 to 13. So it's very low in terms of, we also have peer support or rehab counselors who join the clinicians. The clinical team may include clinicians, the peer partners or family partners, the psychiatrist, and a rehab counselor. And our referrals are normally received through the call center, but you can also contact us directly. Our numbers here at the screen, 287-6200. The program supervisor is Marcella Pillay. I am the program manager, and Amy Rice can also be contacted. She's our senior program manager. And thank you.
Thank you so much, Bernadette. Now, next I'd like to introduce May Sampani from Uplift with Placement Supportive Services. May?
Hi, thank you, Melissa. I'm just gonna wait for, oh, there it is. Thank you so much. Again, my name is May Sampani. I'm a clinical director overseeing Placement Supportive Services, or PSS. Next slide. Just a summary of the services that we do is that PSS is a 60-day program to provide stabilization services through individual, intensive brief therapeutic treatment, crisis stabilization to children, youth, and non-minor dependents. So typically we see kids from 0 to 21. Referrals are typically coming from the placement unit, and those that are at risk of losing their home placement, kids that are in foster homes that may be typically receiving a 7-day to 14-day notices, even supporting kids that are coming out of STRTP or services, or kids that are, again, typically might be at risk or have already lost placement, and that they are on their way to either the Kiki Center or any of the satellite homes. So in the program, there is a 60-day professional parent attached to the program. It's placement. So they come along with the PSS team. And then they can also provide a 24/7 in-placement support as needed to really stabilize placement and avoid losing and disrupting that current placement that they have. The team also is part of a what we call an SBQR, which is an on-call system after hours, as well as over the weekend and the holidays. One of the key components of PSS is that, services can be in place either waking hours or, like I mentioned, 24/7. One of the key factors that we have in PSS is that the 2 tracks that we have at this point, and I can speak to that after the next slide, please. So the service delivery we have is that when I'm sorry, the next slide. Thank you. All referrals come exclusively from the DFCS placement, and typically social workers will send that referrals to them. The placement unit is the gatekeeper, and once they meet criteria, they will then be referred to PSS, and we can open within within a few minutes if needed. So PSS has 2 tracks, as I mentioned. The PSS1 track, if you can click. PSS1 typically involves more high acuity type of kids. These are kids that are chronically AWOLing, substance use, multiple 5150 hospitalization, the CSEC population, a lot of placement disruption of their history. And what we can do is once we get that referral and it's a PSS1 track, we can provide immediate support within 30 minutes to the youth or to their placement. The PSS2 track is much lower acuity, but these are families or kids that are also at risk of losing placement or are needing a lot of behavioral support. Either they're re-entering a home placement or having, because they've been removed, or that they are going back into placement and wanting to stabilize and to do a re-entry to support the family. And at this particular referral, we are able to support within 24 hours. The program can have a 62 capacity, and of course, all PSS referrals must meet medical necessity. And I mentioned this already, so we can go to the next one. Next one. And so I want to just kind of highlight the PSS team at this point. We have 7 facilitators on the team. Yes, we have 4 family partners that work with us, and we have 18 family specialists currently. And a lot of these are, again, can be activated within a few minutes to support a youth in crisis. We have 2 program supervisors, 2 clinical program managers, and wanted to highlight also our language capability. We have staff that speak Spanish, Tagalog, Vietnamese, German, French, Farsi, Cambodian, Hindi, and Punjabi. And also one of the highlights that we have is that we currently have a family search and engagement staff. And this particular staff works with our facilitators and our team to really look into more family finding. And so each of our kids that come through the program will have, if not from the county, but within our program, to have a family search and engagement staff that works along with them to expand their natural support system. And just wanted to also highlight, and this is my last slide, just the 2020 data that we have, and just particularly highlighting the success of the program. 87% of all discharges have reached their treatment goal, and really just highlighting here the amount of work and hours poured in to the team. And again, our mission, our goal is to stabilize placement and also help kids transition and connect them to the resources that they need, and working with them while they're in the midst of their crisis and probably one of the difficult times in their life. So again, if any referrals will need to go through the placement unit, and that's and then they refer kids to PSS directly. And that's all I have. Thank you so much.
Thank you so much, May. Really appreciate it. I'd like to introduce Leah Avila from our Youth System of Care.
Good morning, everybody. Hold on, let me turn the camera. There you go. Hi, everyone. So I am Leah Avila. I'm the referral coordinator with substance use treatment services for adolescents. You can go ahead and switch to the next slide. Just a basic overview of our services. We do serve clients from 13 to 21. So K-age clients are our targeted population as well. We offer outpatient counseling for substance use, as well as intensive outpatient. We treat co-occurring clients, and we do also have residential services for these clients. That includes a 30-day program. People that are eligible are clients that have Medi-Cal or uninsured. We can see some private insurance clients if they are located at one of our school sites. So yeah, and I'll talk a little bit more about the referral process at the end. So we can go ahead and switch to the next slide. This is just other supports that we work with RAP. We do have referrals coming from the ranch, as well as from our inpatient program, which include the warm handoff with the MDTs and outreach presentations. Next slide, please. Okay, so here is just a list of our providers and our locations. We are at several school sites. You know, it's looking a little bit different right now with the pandemic. Obviously, schools are virtual right now, but they are still able to make referrals from the school to the clinicians. So this is, you know, a list of where everybody is at. Some of our contracted providers are, obviously our contracted providers are included, which are Advent, AARS or Health Right 360, and Aki. And then of course our home site, which is Children, Family, and Community Services at our Alexian Clinic, and just all the different schools that we are at, which I can provide a flyer to Melissa to give to all of you guys, so you guys have this on hand, just in case you do come across that occasional client with private insurance. You can, you know, always refer to this to see if they are eligible for services if they attend one of our school sites. So next slide, please. And this is just, you know, kind of another overview of what we offer as far as the individual therapy, family therapy, case management, medication management, and et cetera. Let's see. Yeah, so I guess I'll take this time to go over the referral process. All the referrals come through me. I will do a brief screening with the client, and once that's complete, I will get them connected to a provider. It's usually, the decision I make about the provider is usually just based on demographic. Obviously, right now, the majority of our services are telehealth or virtual. So that is, you know, not the main thing, but I still try to get them connected to someone that's going to be close to them, so that once things do go back to normal, it'll be convenient for them to get to and from treatment. And then this is just our contact information. As you notice, there is my email as well as our new email. There's no wrong door. You know, you can call in, you can send me the referral via our referral form, which I will also be providing to Melissa to send out to you guys. The new referral email is one that they eventually want us to use, that one solely for referrals. But like I said, if you happen to send it to my personal email, it's fine as well. That's pretty much it. And if you have any questions, I'll be able to answer those at the end of the presentation. Thank you.
Thank you so much, Leah. And on that note, if you have questions that have come up on any of the presentations so far, go ahead and start putting those in the Q&A, so that when we get to Q&A, we'll be ready to answer your questions. And I'm going to go ahead and turn it over now to Kelsey Rowland from Seneca to talk about therapeutic visitation.
Great, thank you. Hi, I'm Kelsey Rowland, and I'm the program supervisor for Seneca's Visitation Services here in Santa Clara. And today I'll be presenting on Seneca's Therapeutic Visitation Program. So first, I just want to go over an overview of the different levels of service that we offer in visitation, just to make sure that you refer your family to the appropriate level of service. So real quickly, we do offer a supervised level of visits, and that's our lowest level of care. That's a 60-day program. And in that level, the social worker may refer the family to supervised visits. They might find that the parent already has some established parenting skills. We have a counselor that will provide 100% supervision. We consider the parent to be the client in this level of service. And really our staff are there just to support. They don't want to over intervene. They want to, support the family and having that time and space together. But of course, they're there for support to help create structure and create a safe environment for the family. Our next level of service is enhanced, and that's a 90-day program. This is a higher level of service. And in this case, the parent may need a bit more support in addressing the child's needs. And so a counselor, again, will provide 100% supervision. We'll also add a clinician to the team. And the clinician will provide some observations and assessment of the parent to help make tailored goals, helping the parent meet the child's needs. And so with this level of service, again, the parent is the client, and the counselor and the clinician will be supporting the parent to meet the child's needs during visits. And then our last level of service for visitation is therapeutic, and that's what I want to focus on today. And so for therapeutic, depending on the insurance that we bill, it can be 180 to 240-day program. The youth has some higher needs and does need to meet medical necessity to be eligible for this level of care. And in this case, the clinician is the one who supervises the visit and provides therapeutic modalities to help the family improve their interactions. So again, for this level of service for therapeutic, the youth is the client, and the clinician will be addressing the youth's needs as they interact with the family and parent during visits. Next slide. Go ahead and next slide. So the target population is, we work with children that are dependents of Santa Clara Child Welfare. 0 to 18 are the ages that we work with. And we primarily work with families in reunification services, although sometimes we can do also connection visits. Insurance for therapeutic visitation is, we do bill Medi-Cal. However, if they don't have Medi-Cal, don't worry, we can still work with it. And as far as the service, again, it's a safe setting for the parent and child to visit. It's an opportunity to address feelings of trauma and loss. Our clinician will use strength-based, family-focused interventions to help improve communication and their interactions. And our clinician will use, age-appropriate communication and verbal interventions to help the interactions between the parent and child during visits. Our program, we're located, the visits would be at our Seneca Visitation Office. We have sites in San Jose and Gilroy. And then again, to be eligible for therapeutic visitation, the child must meet medical necessity and the family should be entitled to visitation services. Of course, during COVID, we do offer virtual and in-person visits. Next slide. And then the referral process, it's same as if a social worker were to refer for other visitation services through the county. And so for this program, you would fill out a specific therapeutic visitation referral form, send it to the DFCS visitation schedulers or Byron Myers, and that will be passed on to us. And once we open the case, the clinician will do a full CANS assessment of the youth, and they'll determine the length and frequency of therapeutic visits. And then this is our contact information. So feel free to email our this email address, or you can contact myself, or our program director. Thank you.
Thank you so much, Kelsey, for sharing about therapeutic visitation. Really appreciate your presentation. And that concludes all of our presentations for today. We will be opening it up for Q&A. If you'd like to place a question in the chat, we will have some time for our presenters to respond to your questions. So go ahead and click the little Q&A button and type your questions in. We will go ahead and respond. So we had one question from Susan Steele, who can contact the service providers to get services, caregivers. So for kids that are in the system, child dependents, their services, well, I'll let Gail answer this question. Gail?
For children that are receiving services through the Department of Family and Children's Services, the social worker would make a referral through the Pathways to Wellbeing Behavioral Health Coordinators using the SCZ 61. And then you can also send any questions to BHSD Pathways, and that's a email address that somebody is at all day and will be able to answer any questions you have. Does that answer your question, Susan? Okay.
Thank you, Gail. We appreciate that. So just to go over one of the other questions in the Q&A, it is asking about the availability of the PowerPoint that we used today. So what we're going to do is we're going to email it to our attendees, and we will also be posting the presentation along with the agencies that presented all their handouts and materials on the community prevention website. So we will send an email later with a link to access those on the website as well. And there was one more question about our survey. So I'm going to let Melissa talk about the survey a little bit, and then I'm going to post in the Q&A the link to the survey. If you all can just copy and paste that into an internet browser and complete that survey, that would really help us a lot.
Thank you, Bertha. So we'll go ahead and go to the next slide about the survey. So the reason we do a survey, we've done one for the last 3 years that we've had this resource fair, is that we just want to make sure that we're bringing the resources to you. This resource fair is very different, obviously, this year because of COVID and virtual. We're not able to share quite as many in-depth information about programs that we have in previous years, but we're attempting to put it together for you in a virtual format so that you can get some information about programs you may not have heard before. This particular webinar, we started with our least intensive services, prevention and early intervention, and moved towards more intensive services, and also shared the information about specialized programming and SETS programming. So please do complete the survey. You will be invited to put your name in the survey, and if you do that, you'll have a chance to win a Starbucks gift card, and just to thank you for your participation in the survey. Next slide, please. So if there are any final questions, we'll have time to take those at the very end, I think. But I just wanted to highlight one event that's happening today before we close. Today is our Santa Clara County Recognized Day for the National Day of Racial Healing. And so this afternoon at 3:30, there will be an event, and we invite you to join the community in this event. We're going to try to put a link to the virtual gathering in the Q&A. And the movement for the National Day of Racial Healing is really a national movement designed to lift interconnectedness, promote social justice, and heal the harms of inequity through community relationships and structural change. It's a day to share truth, deepen relationships, and build trust to create a more just and equitable world. And the honoring and celebration of the National Day of Racial Healing builds on the collective healing work happening in Santa Clara County, while encouraging systems and individuals to reflect and act in a deeper, more meaningful way that speaks to our declared values of racial equity. The County of Santa Clara's theme for 2021 is Healing Through Justice, Truth, and Equity. Black Lives Are Sacred. And so we hope to see you there this afternoon. Bertha, are there any other questions that have come up in the chat for us to address?
There was another question that came up from Susan Steele as to whether caregivers get copies of the case plans.
So Susan, if you're talking about the treatment plan prepared by the behavioral health provider, it would have to be done with a release of information in order to share that. Any other questions that have come up for people before we close? I'll leave it open for another minute.
I'm going to type in the link to the Racial Healing, National Day of Racial Healing event for you all to have as well, as Patty Pena asked that in the chat.
Okay. It looks like that concludes our presentation for today. Next slide, Frank. I just want to take a moment to thank all of our attendees for joining us today to learn a little bit more about the behavioral health services available in Santa Clara County. I want to thank our planning committee, and most importantly, want to thank our panelists for coming and sharing with us today. And again, we really hope that you can complete the survey, and we hope that you will be able to attend the National Day of Racial Healing. We're going to be sending the handout to our registered guests. We have some brochures and materials that would be helpful for you, and plan to have the recording available soon. And we thank you very much and hope you have a wonderful day and week.